Welcome to the Own Your Voice series. I'm Dr. Samantha Deloche, pharmacist, speaker, and founder of Model Speakers Academy. This series is dedicated to elevating conversations that matter, conversations that educate, empower, and most importantly, humanize healthcare. Today's discussion is a part of our HIV awareness and education initiative, where we are intentionally highlighting both the provider perspective and the patient experience because meaningful care happens when both voices are heard. I'm honored to be joined by Dr. Crystal Mackie, who brings not only clinical expertise, but also compassion and commitment to the work that she does every day. Thank you so much for being here and for the impact you make in our communities. And I would be remiss if I did not mention Gilead Sciences Incorporated for sponsoring this platform. Thank you so much, Gilead.
Thank you so much for having me. I'm glad to be here.
Yes, so let's start by helping our audience get to know you. Can you share a bit about your professional background and your current role in healthcare?
Sure. So I am a family physician. I work at C.W. Williams Community Health Center, where I function as a family physician and also their associate chief medical officer.
So what, originally drew you into healthcare and specifically into working in this area of HIV care?
Sure. So I believe that I was led into healthcare. I grew up one of two from a single mom, and she worked really, really hard to try to make ends meet, but it was difficult for her. And so there were a lot of people in our community that pitched in to help to make sure that we didn't go hungry, that we had clothes. There were coaches that reached out to help. So I realized very, very young that there were a lot of people that were playing a part in making sure that my family had the things that we needed. And I knew that that was what I wanted to do for other people. I wanted to reach out. I wanted to help. I just didn't know how. It just so happened that I ended up in medical school, did well, and fell in love with family medicine because I got to see everything. So I got to see the babies, the moms, the dads. And I feel as though family medicine allows for us to not just treat a patient with medicine, but to treat the entire patient. So talking about their social backgrounds, their economic backgrounds, their mental health, family medicine wraps around a patient. So that's how I got into medicine and why I chose family medicine.
Beautiful, your own life experiences and wanting to give back and pretty much be what others were for you.
Yes.
So that's amazing. So let's now talk about the reality of the work. In your current role, what does a typical day look like when caring for patients impacted by or at risk for HIV?
So we have, like I said, everyone in family medicine, and the conversation starts with the young children. So depending on who I'm seeing, the conversation can be a little bit different. I'm a very large advocate, big advocate for PrEP. So even if I'm not seeing a patient diagnosed with HIV, I am educating patients that may be sexually active or may be becoming sexually active about the opportunities to prevent HIV. PrEP therapy is something that's not commonly discussed. A lot of patients have not heard of it when I bring it up. A lot of women are not aware that they qualify for it because of some of the stigmas that are associated with HIV and it being a gay men's disease when it was first found. And so they don't realize the risk that they have. So these patients may come in for a well woman exam, a physical exam, and I'm bringing up at least PrEP, telling them that they can prevent HIV by taking certain medications. For the patients that are HIV positive, when they come in, I want to, again, make sure that I'm wrapping around the entire patient. So while we're talking about their CD4 count, while we're talking about their viral load, I'm also asking them about their social situations. Do you feel safe at home? Are you currently in a relationship? Do we need to talk to that that partner that you have about PrEP? Or do we need to get them treatment if they're positive and they're not on treatment? I want to know what their mental health looks like. Who are you talking to about this? Are you experiencing depression? So we go through those questions during the visit. I like to make sure that they have their medications, that they're not having side effects from the medications, because if someone's taking a medication and they don't tolerate it well, they're not going to take it.
Basically.
So I have to ask those questions.
Right.
Are you dealing with the medication? What are you interested in some of the longer acting medications? Because we don't just have pills now, we also have injections. So patients can come in every 2 months. Hopefully, there'll be some every 6 months injections coming up for HIV, and just trying to see if we're maximizing all the options. There's screening tests that we have to make sure that the patients are getting. So they're at risk for certain types of cancers, depending on the type of infections that they may have had in the past. So they require more frequent screening than some of the other patients. And so I make sure that I'm doing that as well. Sometimes it's difficult to start those conversations. And so I have to make sure that I'm meeting them on a human level. My father was a substance abuse user. He was on drugs for a long period of time and actually contracted HIV and died from AIDS. And so I know what it looks like to have someone to not take care of themselves, and the stress and the strain of trying to figure out where you fit in life. And so I bring that to the table when I need to, because I want them to know that I understand. I
Right.
understand on a physician level, but I also understand on a human level, and I'm here for you in any capacity that you need. And so that can sometimes allow patients to feel more comfortable to tell me what's
Absolutely.
going on with them, to tell me exactly what it is that they need from us so that we can support them. We get labs from them every 3 months to make
Okay.
sure that they're healthy. And then we also have case managers that will contact them outside of the clinic, call them when they're at home, and just touch base and make sure that they're doing okay.
Wow, that's so good. You said a mouthful. I love how you mentioned the humanistic part,
Mhm.
because some patients feel like they're just a number. They're a medical record number. They're somebody on the list to get checked off. And thank you for your transparency
Sure.
about your own personal experience, because that does make a difference.
Hmm.
You're not looking down on the patients, but you're trying to bring them up.
Right.
You're trying to help elevate them. So thank you for sharing that.
Sure.
So, what are some of the most common or stigmas you still see surrounding HIV prevention, treatment, or care today?
Sure. So as I mentioned before, the stigma of this being a gay man's disease, it is not. One of the most rapid growing populations of HIV are African American women. And a lot of that is because of that, misconception that they're not at risk. And so I do a lot of talking about socially our culture as African Americans, and how we don't allow for some uncomfortable conversations to be had. The stigma that I grew up when I told people that, my dad had HIV, I learned very quickly not to do that, because they thought that if they touched me, they would get it.
Right.
Or if they breathed the same air that I did, that they would get it. They assumed that because he had it, I had it. And
Right.
so I understand that there's a lot of misinformation, and it makes it difficult for people to even wrap their head around, going on PrEP, especially African American
Mhm.
women. But when you have a culture where masculinity is very, very important, men don't necessarily want to have the conversation that, well, I'm bisexual. I have
Right.
sex with men and women.
Right.
And so they hide those things, and that could put their female partner at risk. And so I'm
Right.
telling women that if you're in a relationship and you're not 100% sure that, that relationship is monogamous, you need to protect yourself. You take your own care into your own hands. And then we
Right.
start having that conversation about PrEP. But that is a really big misconception that causes a lot of, confusion. And then the same thing on the men's side, a lot of men believe that because I'm having sex with only women, I can't catch it. And that's not true, because women do catch HIV. There are women that are walking around with HIV that don't know it. And so the men don't know that they're at risk because they're not having sex with men. And then the treatment, when antiretrovirals were first being established as treatment for HIV, they were very hard to tolerate. They made patients sick. And so a lot of people who are diagnosed with HIV, they feel as though they're going to be taking these medicines that are going to make them ill, that
Mhm.
are going to have strong side effects, and they don't want to take them. They're like, I've been fine for
Right.
this long. And, I try to tell them that we're coming up with different things all the time. Medicine is constantly changing, which is one
Right.
of the things I love about it. It's constantly
Absolutely.
expanding and growing. And so the medications that we have now are not the medications that came out in the 80s. You're able to take these medications and live a pretty much normal life as long as you're taking them appropriately. You don't have to take a pill every day. You can come in every 2 months and get an injection.
Mm-hmm.
So I'm trying to make sure that I'm giving as much information as possible to those that need it to kind of dispel some of those thoughts that may have caused people to have these misconceptions about HIV as much as I can.
Okay. Okay. So, how do these stigmas show up in real life in patient behavior, access to care, or adherence to treatment?
There's a lot of avoidant behavior with some of the patients that know that they have the diagnosis because they don't want other people to know. They don't want
Right.
people to look at them a certain way or have certain beliefs about them. And so sometimes it's very difficult to keep them on the regimen and to keep them coming back for all of the care that they
Mhm.
require because again this is a team effort. There are so many different things that we have to make sure that they have access to. The insurance company has gotten better, but there's still lots of roadblocks. There are medications that are much better tolerated, and they are not necessarily the first line. Sometimes we
Mhm.
have to do what's called a prior authorization, where we have
Yes.
to prove to the insurance company that
Right.
this medication is the best medication for this patient. And it may not be based on one of the indications that's on the label for the
Right.
medication. It may be a social thing. Some patients may not want to take a pill every day because that means every day they're waking up and they're taking a reminder that they have this thing that they constantly have to deal with. They may not be in a headspace to have that thought process every morning. And so the injection may actually help to take some of that off and give them a little bit of relief. But I have to prove that to the insurance companies. And so that can
Right.
be difficult at times. We have case managers because of some of the avoidant behavior that you get with patients and not wanting to come in because they don't want to be seen as that patient. Recently, I had a pregnant patient who was
Mm.
diagnosed with HIV who was refusing to take medication because she did not want to put that medicine in her baby's body. But what we were trying to get her to understand was the risks and the benefits of the medications. The risks of not taking the medication could be that you transmit this illness to your child.
Absolutely.
Whereas if you take this medication for, 41, 42 weeks, then you can prevent them from having to deal with this for the rest of their life. You can make this sacrifice for your baby. And it was a really difficult conversation because she didn't want to be seen as a mother that was putting chemicals in her baby's body. So we
Mhm.
had to educate her on the risks and benefits of that.
Wow, that's so good because that's a real thing.
Hmm.
Many people take herbals and supplements and, other,
Hmm.
drugs and alcohol,
Hmm.
and but they see prescription drugs as
Right,
different,
right.
and so
There's a real push for more holistic care
right.
nowadays, and
Yes.
I support that actually. But again, it's all risks and benefits. And if your holistic care can be a great adjunct to the medical care that we give, I think that's fabulous because I don't think we should be limiting ourselves to any one thing.
That's
We should
true.
use everything that we have to make sure that we're healthy and we're safe. And so if you're into holistic care, let's sit down, let's have that conversation. But let's also take into consideration that that may not be the thing that is sustaining you. It may help you feel better. It may boost your immune system,
Mhm.
but it may not sustain you overall. So there may be a combination that's needed.
Work, yeah, so that's very important for people to hear. So I wanna shift us toward progress and possibility. From your perspective, what progress have you seen in HIV treatment and prevention that gives you hope? And I think you kind of touched on it with the new drug
Yes.
treatments.
Oh my goodness.
Yes.
The injectables. I am so excited about the injectables and the hope that there may at some point be an injectable that's available that patients only have to take twice a year. I
Wow.
understand that there are trials in place right now
Okay.
that there may be an injectable for once a year. And
Ooh,
so it's like going in and getting a vaccination
right.
almost. And
Hmm.
so I'm so excited because, again, it lifts that reminder.
Yeah.
Some patients struggle with depression, they struggle with anxiety, and having to take those pills and go in and get your refills and then, sit and talk to the doctors over and over and over every month, that can add to some of the, mental health factors they're already dealing with. So
Correct.
these injectables I'm so excited about. And I understand that this is something that's coming within the next couple of years, the
Wow.
once or twice a year injectables for treatment.
Hmm.
We do have a twice a year PrEP, so preventative medication that is already out there. And I have patients that are signing up for it left and right. So I'm
Wow.
excited about that. But the biggest thing are the injectables for me. I'm really excited about those.
Yeah, I can tell. And that is great news. I think some people are afraid of needles, but what would you rather take a pill every day or get a needle once a year or twice a year?
And you'd be surprised how many patients will be like, okay, I'm just going to close my eyes and grit it and it's done.
It's done.
Yep.
That's right. So, what role do trust and communication play in effective HIV care, especially for patients who may feel fear, shame, or uncertainty?
A huge role. If
Right.
the patient doesn't trust you, they're not going to give you their information. They're not
Mm-mm.
going to tell you what's going on with them socially, and you're going to miss the opportunity to help that patient. You have to make sure that there is a level of trust between the provider and the patient. And I always tell my patients that I feel honored that they're allowing me into a very private space with
Mhm.
them when we have these conversations, because it's hard to talk about this stuff. And I see that and I understand that. And so I build trust. Again, if I have to reveal things about myself and the things that I've experienced, I do that because I
Right.
want them to understand that I'm coming at you from a human level. I'm side by side with you. I'm not above you looking down. And that
Mhm.
actually allows for the patients to feel comfortable when they come
Yes.
in. They're bringing me all the information that we need to make sure that they're taken care of. There's something called doxypep, where you take antibiotics after sexual intercourse to decrease the risk of other sexually transmitted infections like gonorrhea, chlamydia, trichomonas. And so if I know that you're going to sex parties, which may not be something that you would tell your regular doctor,
Exactly.
then I can offer you that. I can tell you that, hey, that's probably not the best thing for you. But if that is the lifestyle that you choose, I can support you in this way. And so making sure that there is a level of trust is really, really important.
Yes, because you can allow them to be more vulnerable, and then you're letting them know this is a judgment-free zone.
Right,
I'm here to help you in
right,
whatever you choose or decide, but I'm not here to cast judgment.
exactly.
That's a beautiful thing. So, how do you personally approach conversations with patients who are newly diagnosed or hesitant about treatment options?
I'm straightforward with the diagnosis. I talk to them on a scientific level first. I
Okay.
tell them this is what the lab test is showing, and this is what this means. I allow them to process that because
Mhm.
that's a big thing. This is not COVID. It's
Right.
not something that you're going to have for a couple of weeks and then your body's going to get rid of it. This is something that you're always going to have. And you're going to have that plus the stigma that comes with it, plus the worries that come with it, plus the conversations that come with it. So I allow them to process that information. I ask them, do you want me to stay in the room while you think about this, or do you need some space?
Mhm.
I'll leave the room if they need me to sometimes so
Mhm.
that they can just think and be along with their thoughts. And then I'll come back in and I ask them, what are you thinking? What are you feeling? How can I support you in this moment? And then we start from there. A lot of times they want to know where they got it from. And I tell them, I can't guarantee and tell you where you got it from, but I can tell you that there's help for you
Mhm.
and that this is not something that is going to ruin your life. This is something that you can live with and you can live freely with it as long as you're taking your medication and you're staying on top of your treatment. And then I asked them again, how can I support you? I asked them that over and over again because in the beginning, there's kind of a shock
Yeah.
that they go through. And so they may not know right away what it is they need or how they need help. So I let them think about that. And then I have them come right back. I don't say, okay, well, you have this diagnosis. Here are your pills. I'll see you in 3 months for lab work.
Right.
I bring them right back and we have the exact same conversations. And I say, we have a behavioral health team where you can talk to a social worker. We have therapy, we have psychiatrists. How can I help you? What is it that you need from me? Do we need to have a conversation with a partner? Are there any family members that you want me to mediate a conversation with? I try to make sure that any way that I can think of, I offer them because they may not be able to think of it in that moment. And sometimes I have patients that just say, Doc, I need to go home and process this. And at that point, I say, okay, but let's go ahead and put an appointment on the books so that I can reach out to you, you can reach out to me, and we have that avenue for communication. So I really just follow their lead and I let them know again that, there's no judgment here. There's no judgment, and I'm here for whatever it is that you need. And I just allow them to tell me what it is that they need.
Wow. And just hearing you talk about it, I can just feel the compassion that you have for your patients. And honestly, what you're saying is really what all doctors should be able to do. But, oftentimes with the limitations of insurance and just the patient load, the schedules,
Yep.
it's hard to take that one-on-one time. But I love your approach of, allowing them to digest it and not just throwing a prescription at it, but how can I help you?
Right.
That's such a good thing. So what do you wish more people, both patients and the general public, truly understood about living with HIV today?
That it is not a death sentence. The pathway that my father went down when he was diagnosed, and he died in the 90s, is not the same pathway that patients have now. There's so many different medications. There's so many systems that are available for patients who have insurance. Even if you don't have insurance, you can still reach out and get help. There's so many programs that are available, but just that you can still live a full, healthy, and happy life. That is what I want them to know, because I think that HIV in and of itself causes a certain mind frame that makes you feel as though everything is over. And that is so not true.
Right. And to wrap it up, I'd love to zoom out a bit. What advice would you give to healthcare providers who may not specialize in HIV care, but still serve patients who need education, compassion, and support?
Don't be afraid to have the conversations. In the beginnings, it can be scary when you are stepping into that realm. But if you just look at the patient as a person and in that moment tap into your humanity, it gets easier and you may save so many lives in the process. So don't be afraid to have the conversation. Don't be afraid to talk about PrEP and prevention. Don't be afraid to talk about the options and treatments. And if you don't know, if you want to learn, reach out. There are so many different programs and conferences and even pharmaceutical companies that will come out and educate you. Look for the answers. Don't be afraid to step out into an area that you might be afraid of because of a stigma, but reach around that and try to educate yourself so that you can educate others. It's so worth it. You'll save so many lives.
So my final question would be, when you hear the phrase "own your voice," what does that mean to you as a provider in the work you do every day?
I think as a provider, what that means to me is that it's my responsibility to use the platform that I have to reach as many people as I can. And so I have to make sure that I'm giving out the best information for the patient that's sitting in front of me or the patients that may be listening or I may run into. But I want to make sure that the words that I speak, there's something called the Hippocratic Oath that the doctors have to pledge that we do no harm. I go above that. And I think that owning your voice as a provider is to go beyond that, not just to not do harm, but to find ways to do good. Find ways to stand up for the things that you believe in, even if it might be something that's uncomfortable, like HIV care. It's not something that everybody, looks at with roses and butterflies, but it's something that's super important that can reach a lot of people and save a lot of lives. And so don't be afraid to stand up for those patients who may not be able to stand up for themselves, because people may be more in tune to listen to you than those people that don't have the platform that you have. So use your voice to do more than just not do harm. Use your voice to do as much good as you can.
Oh, that's beautiful and very true, very timely.
Thank you.
Thank you so much for sharing your time, your insight, and your heart with us today, Crystal. Conversations like this are exactly why the Own Your Voice series exists, to educate, to break stigma, and to remind people that compassionate care begins with understanding. To everyone watching, thank you for being part of this conversation. We encourage you to continue learning, asking questions, and showing up with empathy. Also, again, special thanks to Gilead Services for allowing this platform to take place. Until next time, remember, your voice matters. I'm Dr. Samantha Deloche.